Welcome. Today, we're really focusing on cardiovascular medication safety during pregnancy. We want to get straight to the clinical recommendations you need to know right now.
That's right. The goal is to pull out the essential information on teratogenic risks, how these drugs can harm the fetus. For all the healthcare providers listening, we need clear lines, what's safe and what's absolutely off limits.
Okay, let's get right into it then. It can feel like a minefield sometimes. We have to start with the drugs that are, well, non-negotiable stops. What are the big classes, the main ones, strictly contraindicated in pregnancy?
Yeah, there are four major groups we need to flag immediately. First, angiotensin-converting enzyme inhibitors. Then, angiotensin receptor blockers, also statins. And finally, mineralocorticoid receptor antagonists. These pose the highest risk.
Let's break those down. Angiotensin-converting enzyme inhibitors first. So drugs like enalapril or ramipril, what are the specific risks to the fetus, and what's the mechanism happening there?
Well, the core problem is that they interfere directly with the fetal renin-angiotensin system. This system is absolutely crucial, especially in the second and third trimesters, for kidney development and fluid balance.
Okay.
So when you disrupt that, you see some really severe effects. Oligohydramnios, that's low amniotic fluid, fetal renal failure, intrauterine growth restriction, even skull hypoplasia, problems with skull development.
Those outcomes sound devastating. So the critical advice for a patient taking an angiotensin-converting enzyme inhibitor, what do you do?
The standard of care is really clear on this. Discontinue the drug before conception. That's the ideal. If pregnancy occurs while on the medication, stop it immediately, doesn't matter the trimester, and then get a prompt, detailed assessment of the fetus underway.
Right. Now, what if the patient needs that RAS system blockade? Do angiotensin receptor blockers, ARBs like losartan or valsartan, offer a safer path?
No, absolutely not. That's a common misconception. ARBs carry the same level of fetal risk because they work through that very same mechanism, disrupting the renin-angiotensin system.
So no substituting?
Definitely not. You cannot switch from an angiotensin-converting enzyme inhibitor to an angiotensin receptor blocker during pregnancy, thinking you're making it safer. The risk is identical.
Okay, we've nailed down the RAS inhibitors. Let's pivot to cholesterol management. Statins like simvastatin, atorvastatin, why are these a definite no during pregnancy?
It comes down to basic fetal biology. Statins work by blocking cholesterol synthesis. And cholesterol isn't just bad fat in a developing fetus, it's fundamental.
Fundamental how?
It's the building block for essential steroids, for cell membranes, for myelination of nerves. It's needed constantly for growth and development. Because of this continuous need, statins are contraindicated through all 3 trimesters.
Makes sense. Okay, the last one in this high-risk category, mineralocorticoid receptor antagonists. Specifically thinking about spironolactone here, what's the precise danger with that one?
Spironolactone's issue is its anti-androgenic effect. This means it opposes male hormones. So if used during pregnancy, there's a real risk of potential feminization in a developing male fetus.
Wow.
Yeah, because of that potential for permanent hormonal interference, it's another one that has to be avoided throughout the entire pregnancy.
All right, that covers the absolute contraindications. Let's move to the options we can actually use. For managing hypertension in pregnancy, which beta blockers are generally seen as safe, maybe even preferred.
Labetalol usually comes out on top. It's generally considered safe, it's effective, and it's often the first choice for managing both chronic high blood pressure and acute hypertensive crises during pregnancy.
Okay, labetalol is the go-to. But is there any beta blocker we need to be a bit more cautious about, even within that generally safer class?
Yes, there is. Etalol specifically. While it is a beta blocker, studies have linked it to fetal growth restriction, particularly if it started early in the pregnancy.
Okay.
So while labetalol is preferred, the key takeaway is you always need to monitor fetal growth closely whenever any beta blocker is used during pregnancy. Vigilance is key.
Good point. Now, calcium channel blockers, CCBs. Thinking of drugs like nifedipine or amlodipine, what's the general feeling about their safety?
Calcium channel blockers are widely regarded as safe and effective for maternal hypertension too. Importantly, there's no confirmed evidence suggesting they cause birth defects. No teratogenic risk has been established.
That's reassuring. And nifedipine specifically, it has another use in obstetrics besides just blood pressure, doesn't it?
It does,
Yeah.
yes. Nifedipine is interesting because it's also used for tucolysis,
Tocolysis, meaning?
meaning suppression of preterm labor. So it can safely help manage blood pressure, and it can also be used in certain situations to help stop early contractions.
Right, okay. Versatile. Now let's shift to our use with caution category. Thiazide diuretics like bendroflumethiazide. When would we even consider these? They aren't the first thing we reach for, are they?
No, definitely not first line for hypertension in pregnancy.
Right.
Really, you'd only consider using them, and very cautiously, if you're managing a patient with significant heart failure who also has considerable fluid overload. That's a specific, more complex scenario.
And why the caution? What's the mechanism we're worried about with thiazides?
The concern is that their action, reducing fluid volume, might potentially impair blood flow through the placenta. Placental perfusion is vital, of course.
Of course.
And this impairment could, theoretically, lead to fetal electrolyte imbalances. So if you do use them, it requires really close monitoring of both mother and baby.
Got it. Okay, let's talk about antiplatelet agents. Aspirin comes to mind. What's the guidance there? Is it safe? What dose?
Low-dose aspirin is considered safe, and when we say low dose, we mean specifically in the range of 75 to 150 milligrams per day.
75 to 150 milligrams. Okay. And what's the main reason we'd use low-dose aspirin during pregnancy?
The primary use is prevention. It's recommended for women identified as being at high risk for developing preeclampsia. It helps reduce that risk.
Preeclampsia prevention. Okay. But what about higher doses of aspirin? Are there risks there?
Yes, absolutely. High doses of aspirin must be avoided. There's a risk of causing premature closure of a fetal blood vessel called the ductus arteriosus. Plus, there are significant bleeding risks for both the mother and the fetus, especially around the time of delivery.
Very clear distinction there between low and high dose. Okay, let's do a quick recap. Really nail this down. The 4 classes strictly contraindicated, just list them again.
Sure. Angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, statins, and spironolactone. Those are the absolute stop medications.
Mandatory stops. Got it. And the ones generally considered safe or preferred.
Labetalol is the preferred beta blocker. Calcium channel blockers, like nifedipine, and low-dose aspirin, specifically 75 to 150 milligrams.
And the one requiring special caution?
That would be the thiazide diuretics, reserved mainly for heart failure with fluid overload and needing careful monitoring.
Perfect. So bringing it all together, if you're advising a patient before pregnancy, or maybe they've just found out they're pregnant, what's the most critical action item?
Plan ahead. The ideal time is preconception. Stop those high-risk medications before pregnancy begins. If exposure has already happened, then immediate cessation and really close, continuous monitoring of fetal well-being are non-negotiable. The risks are real and time-sensitive.
It really underscores the responsibility, doesn't it? Balancing the mother's cardiovascular needs with protecting the developing fetus. Knowing these categories, the forbidden, the safe, the conditional, is just fundamental to providing good care.
Exactly. And that brings up a point for you, the provider listening. We know these risks are well established, especially the damage from things like angiotensin-converting enzyme inhibitors or statins in later trimesters. So the question becomes, how can we collectively get better at preconception planning? How do we ensure near 100% adherence to stopping these drugs before pregnancy? Is it about patient education? Is it our follow-up systems? Something to think about in your own practice. How are you ensuring that crucial preconception counseling happens effectively?